Thank you. Actually, I will be discussing only PTMC, the procedure, and some of the things that are unusual for it. This is all the procedures are done with our structural heart team. It now expanded almost more than 50 persons. Basically, for a case of rheumatic heart, a careful history and a meticulous physical examination is must. Now the trend is only for echo. I think we should have a talk with the patient and examine the patient for assessing the severity of the disease and the effect of disease is having or is likely to have on the patient and his or her CVS. The timing and type of the intervention to correct the lesion then is to be decided. Basically, for predicting outcome, very common score, the Wilkin score, you all people know. A score of less than 8 are more likely to have a good result than more than 8. So a valve which is pliable, non-calcific, minimal fusion of the subvalvular apparatus achieve the best immediate and long-term results. These are the parameters we see in the Wilkins score. Now to start with PTMC, this is very important that you should put the venous sheath almost 1.5 centimeter below the arterial sheath, just to avoid the ligament and other structures, because here you have to take a very bulky device for procedure. So access should be a little bit lower than the arterial access. In the start, although it is recommended rather, but we usually don't do the LV angiogram. But if some patient has any mild or moderate MR, then you must do a LV angiogram to quantify. Then through the venous access, the main problem our colleagues face in putting the wire in the SVC. At times the wire curl around in the RA and patient has atrial tachycardia or at times AF. It's very important you know the anatomy and embryology. Basically the IVC and SVC and this lateral part of the RA, they all develop in the same time in the embryology. So this is the smooth part of the RA. So we just put the Mullen sheath pointing towards lateral side and just slide the wire. It will go into the SVC and at time in the subclavian. Then in the subclavian, you just pull the device with the wire and put it into the left subclavian, from SVC to left subclavian. This is very much needed, rather mandatory for better alignment in the puncture line. Now you under vision, always go under vision when you are introducing the Brocken-Bro needle. Always go under vision. You see the Brocken-Bro needle is gone up and it's just 1 centimeter before the dilator, it was stopped. This is done by Mr. Inoue, who has developed this technique, rather developed this balloon, and he did it for the septal puncture. He just do a RV angiogram and then he marked this tricuspid area as point A, and in the levo phase when the dye comes into the LA, he mark another area that is point B, the most lateral part, and then in the middle a perpendicular line is drawn in the middle, and then the lowest part of the LA was again marked. This part was marked, and then from this mark, one intervertebral disc above, you go and puncture the septum. This is the diagrammatic representation, and now Mr. Tom said, are you confused or not? Yes. Confused? Okay, we'll proceed. Okay? This is our technique of delineating the septum. It was initially when we were in the beginner and problem with delineating the septum with Kundi Saab and with Azam Shafkat. We did 4 or 5 cases in this type. In this, an esophagogram is done. Esophagogram is done. The dye highlights the RA border here, and then in the levo phase, This is the RA border, and then in the levo phase, whole of the LA is seen, the perpendicular border and the horizontal border. This luxury was very much you can enjoy when you have a biplane. We have biplane way back. We did 1-2 cases there also. So in biplane you just puncture this. This is basically the driving wheel, the hub of the broken bone needle. You must know that this pointing side is the reference point. If someone say 3 o'clock, 4 o'clock, 5 o'clock, the 3 o'clock means the left shoulder of the patient, and 6 o'clock is just opposite the right shoulder, and then rather 9 o'clock, and then 6 o'clock backside and 12 o'clock up. So you must know that the hub, which way you have to move during your procedure. Now you pull the whole assembly from subclavian SVCR dip, and then another dip into the area where you have to puncture, that is fossa vallis. Now you are in the fossa vallis, then you just see the lower end of the pigtail, which is in the right coronary, non-coronary cusp. Your lower end of the pigtail, just a disc space. Don't count from here. This is puncture needle. There is a sheath, dilator. So one disc space below, you just hold on there and then do a fluoro from AP to lateral view. In lateral view, you can see we just take from a line is drawn from the vertebral column to the pigtail, and 3 subdivisions are done. The middle one is the point where the area where we have to puncture. This slide is borrowed from Navedullah Sahab. Now that you can see a little bit anteriorly and little bit higher, so just pull the catheter below and make it more 4 to 5 o'clock. Now the puncture is done. After the puncture, you just do it in a 1 o'clock position, the sheath and the dilator. And then pull the broken bone needle along with the dilator out. Meanwhile, you have to give heparin also. Although our neuro team is very vigilant, but we have to give heparin. Then the wire, the stainless steel wire 0.025. We put it in the LA, make a roll here. Then a 14 French dilator is used to dilate the excess site and the septum also. These are the inventory that we are using. This is the balloon assembly. This is the balloon here and the intermediate part. These are the vent and the purge area. This is the central line. This is the heart tube which straightens the balloon, and this is the dilator 14 French. This is the rotator that we use for guiding the balloon to the LV, and then this is the syringe with the extension. This is the vernier caliper to size the balloon, and this is basically the stainless steel wire. The balloon has 3 parts. The first half is a balloon when it's inflated. After further inflation, it will become an hourglass. There is the proximal balloon inflate, and in the last, the central part inflates. And this is the total balloon when it was totally inflated. When you stretch this balloon, it becomes 4.5 millimeter or almost 2 inches length. We stretch it with the straightener. This is basically these steps just for you people to see that you have to take care of these things. The vent portion was purged and then locked, and then the main area, the balloon was inflated and deflated from the main port to make it air free. The central area was also flushed. This is the balloon that is being inflated, and then with vernier caliper the sizing is done. So it's 24. This is very important when you prepare the balloon. After preparation, you just go inside the groin at an angle of 45 to 60 degree. Now this balloon assembly is up into the LA after crossing the septum. You can see this round wire. Just hold this assembly at the mid of the circle, at this point. Then after this, you just unlock the system. You see, this is basically septum. The balloon was inside. Then the gray, the hard stillet was unlocked for 2 to 3 centimeters. Then whole assembly was pushed up into the LA, and then the golden hub was also released to unfold the balloon. Now you hold the assembly and just roll over the balloon into the LA pointing towards the LV. These are the steps, but never do that. So because this stillet, it has to be here, not more than above that, because it will perforate the roof of the LA. Now there are two methods. There is a direct method and another is the reverse loop. In direct method, you can see you place the balloon at the mitral valve and then put the stillet just at the mitral valve. You put the stillet and anti-clockwise the stillet and roll the balloon forward. It will go into the LV. You can see that this is a makeshift mitral valve. You see, when the balloon was at the mitral valve level, anti-clockwise, and just pull the wire and slide the balloon inside the LV. You can see the balloon is now at the mitral valve level. Now the balloon is in the LV. Always inflate the balloon from base to apex. Basically, this is the base and this is apex. So always inflate the balloon in the distal part, that is from the apex, and then pull to the mitral valve and then inflate the balloon. Remember, don't pull too much because it may tear the interatrial septum or it may enlarge the interatrial septum. So now the role of Dr. Sattar Sheikh will better you do in the next view. When the hourglass appearance was there, just push the assembly a little bit forward. You see. Yeah. Okay. Then after this, at times when we have a lower puncture, we have to use a technique that is called loop formation. Everyone is basically very much fond of doing this loop formation, but I highly recommend that it's a bailout technique. And in this, one important thing is that you have to make sure that the base to apex is there. Otherwise, most of the time patients end up with MR. So in this, you see the same procedure, but here the stillet, in the direct method, stillet was anti-clockwise. In this loop, reverse loop, stillet, you just make a clockwise rotation. It will make this loop and just push it. Okay. Now the procedure is finished. Again, lock this assembly of the balloon with the stretching tube and then pull the balloon down. Take your pressures and do an LV angiogram. So there is no MR. Actually, this case was done yesterday, only a gradient of 2, an area of 2.1, because it was a private case. This is very unusual, very sad that in our lab we are not doing this. Pre and post gradients documentation. We should do that. These are some unusual cases. This is a subvalvular thickening. You can see that the balloon is inflated and then pushed up. So it's subvalvular thickening. You just inflate the distal balloon and then pull the assembly with little bit force and then inflate. This is someone who begins the PTMC, he uses a undersized balloon. So what happened? At the inflation, the balloon comes out. Okay. Mind you, this balloon you never try to oversize it because it will tear. So if you have to use the actual size, the 24 for 24, 26 for 26. Intermediate size, that is 25, you can make with the 26 balloon. These are some of the complications. You all know. Mortality is around 1 to 2%, but I can't remember for last 1 or 2 years. We have a mortality? One mortality. For surgery, yeah. These are the predictors of mortality, that is echocardiographic score more than 8, increasing age, post-surgical commissurotomy patients, patients who are in functional class 4, those who have a post-procedural PA pressure high, pre-procedural MR and post-procedural MR. They have a high predictors for mortality. So, PMBV is a safe and effective procedure with 95% procedural success and excellent long-term results. Results are dependent on operator experience and morphology of the valve. These are the procedure we are doing in our institute, that is the pregnancy related patients who come with severe MS and in failure. And you can see very severe valve that was very adequately opened. And I think this 100 patients, Javed Shah Sahab has written a paper on this pregnant PTMCs, almost 100 patients. Maybe one of them. उसके बाद लिखना पढ़ना छोड़ दिया ना. This is basically our surgical colleagues. They just refer to us that the Pepsi is very much deranged and RV is down and this and that. We can't do it, you do. So for these compelling indications, these calcified valves we do. You can see the calcium, and now after hourglass it is stretched out. Luckily the MR was not there. This is another case of calcified valve. You can see, you can rather appreciate almost whole of the ring. That was done almost 10 years back with a 20 balloon, multi-track balloon. You can see all around calcium. This also is a very good result. So for in history of NICVD, the PMV is basically started with NOA balloon from 1995 to 98. Then in 98 to 2002, we are doing with the metallic commissurotom. And then now, afterwards, we are using the double balloon, Born-Eifer multi-track balloons. And now, mostly almost 95% NOA balloon, off and on with a multi-track balloon. This is the NOA technique that we are using. This is the metallic valvulotome. It's a two-step procedure, and this is multi-track double balloon technique. Thank you.